I'd like to ask you a question pertaining to my own diagnosis. Okay, I was diagnosed first in December with PAD based on ultrasound. Yesterday, I had the angiogram. So that was good and bad news. On the good side, the my right common iliac artery was found to be partially blocked, 60 to 70%, successfully cleared with ballooning. However, the left common iliac artery was found to be a CTO, right? Chronic total occlusion. I spoke with Kim about this morning. My doctor is didn't evaluate the trying to penetrate, as I understand it, based on his write up. But based on the angiogram, the imaging, decided a Fem bypass was going to be my best option. So what I'm interested in are there techniques, endovascular techniques, that might address my situation with the CTO and the left common iliac artery?
That's right there at the edge of the aorta.
Yeah. I mean,
Yeah.
the first question I've got for you is, how do you feel? What's going on with you?
I feel fine. I have no pain except when walking. I believe I must have developed PAD back in 2017 because that's when I began to experience deep pain in my left hip when walking, and it would disappear upon rest. I saw a number of specialists in orthopedics and spinal. X-rays were done, MRI was done. No one, unfortunately, ever came across or came up with the idea, maybe you have PAD. But otherwise, I feel fine. There's no gangrene, there's no wounds, there's no pain at rest.
Yeah. So I would say that your story is unfortunately a common story for patients who present with what we call as claudication. So the first thing I want to tell you is you're going to do fine. Claudication has very limited risk of ultimately leading to limb loss, right? The natural history of claudication, your symptoms, is not that concerning to me. But that's my perspective as a vascular surgeon. Kim might get upset with me telling you that.
No, actually, I mean, I think that because what questions did I ask you earlier? Mark, you asked me the question, well, do you think I'm going to be okay? What did I tell you? What did I ask you?
You said you'll be fine.
Yeah.
Yep,
Mark, you're going to do fantastic.
I said, you just had your procedure yesterday. No matter what, you can't do anything for 2 weeks. And I said, do you have pain that's waking you up at night? Is your pain actually limiting your lifestyle? Can you do your basic tasks, at least for right now? And do you have wounds and gangrene? And he said, I'm like, you're good for right now.
Yeah.
Well, it limits my lifestyle.
I certainly would tell you a Fem Fem bypass is not an operation that's done for claudication, and it shouldn't be done for claudication. I would not recommend a Fem Fem bypass for claudication.
See,
I would not. And the reason why is, while a Fem Fem is an option to get blood flow in the type of anatomy you have, a Fem Fem bypass requires the use of plastic or prosthetic material. And it also involves the violation of both groins, meaning 2 groin incisions.
Mm-hmm.
The one thing I was worried about for a femoral endarterectomy was 1 groin incision. Now you got 2. And not only do you have 2, but you have a plastic tube connecting the 2 groins. So any issue on one side can instantly become an issue on the other side in the short term. So I would urge you not to get a Fem Fem for your symptoms.
Okay.
Now, your question was, are there endovascular strategies to do this? Absolutely. There's not really one way to do something endovascular, and that's kind of the beauty of it, and allows us all who do these interventions to exercise a little artisanal flair when we do them, because
I love that.
You can treat a blockage of the left common iliac from the arm. You can treat it from the left side. You can treat it from the right side. They have different tools that help us cross these blockages. They have different wires. They have different balloons. They have different stents. And the beautiful thing about it is, if you get 10 different people, you could have 10 different solutions. The one solution that you have been offered is certainly not the solution I would recommend you pursue. So I think a second opinion would result in probably a lot of the same information I just imparted to you. But I'm not sure we're at the Fem Fem spot right now.
Right.
then that's where if it's literally, and we've had people where it has been the last resort, and there's a wound that literally won't heal, and it would just bring a rush of blood flow soonest over there. But even the doctor that did the one that we ended up saying, hey, to the patient, you got to go with this, just get her done, because you're going to lose your leg if you don't. Even the doctor was like, this is not going to last long. I'm just going to warn you. And what he told him is that legs mirror each other. And so what happens in one leg happens in the other. And so the problem that he expressed was that when the feeding leg goes down, both legs are going down, and you have both legs then at that point that are at risk of amputation. But he said they were going to keep an eye on it and see where it went.
Yeah, and I mean, like in those types of situations, they're more advanced open surgical procedures that we can talk about or we can recommend. But certainly right now, that you don't need to have that conversation.
Except that I was always wondering, what about, and I know this is a much bigger procedure, but what if just an aortofemoral bypass?
Yeah.
Because those are pretty durable. Those are like 20 to 30 years we've seen.
Yeah, aortobifemoral bypass. I'm not an advocate for aortounifems, but aortobifemoral bypass is a maximally invasive operation that can be done within 2 to 3 hours. I think is a reasonable amount of time to do one of them. Some people might be able to do them faster. Some people may take a little longer to do them. But it's a bigger stress on your heart. It's a more durable operation, but your risk of cardiac complications goes up. The risk of bleeding goes up. Your hospital stay is going to increase. And I'm not entirely sure it's an operation I'd offer for claudication either, right?
Yeah.
I think that there are lower hanging fruit that can provide you with a pretty durable outcome, addressing your symptoms, all with a needle and wire.
But even with lifestyle limiting claudications, there are significant risks when you perform endo with a patient with aortoiliac disease. Can you go through those and how to mitigate those risks and questions that patients should ask the doctor before a procedure like that?
Yeah. So my bias is I work at a university and I work in a big hospital. And as a result, working in a big hospital, I have a lot more on the shelf readily available to take care of sort of whatever trundles in through the door. One of the biggest concerns I have when I treat iliac artery occlusions is, okay, I've gotten across the blockage. Now I need to open up the blockage. When you open up the blockage, you want to make sure that you don't tear or perforate the artery. Because if you tear the iliac artery, patients bleed. And there's only one endovascular thing you can do in that situation, and that's use a covered stent. And there are a lot of different companies that make covered stents, and there are different types of covered stents. But the way you think about them is they're essentially PVC pipes that prevent blood from falling or going into that torn portion of the artery and out of the blood vessel into the retroperitoneum. So arterial perforation is the biggest concern. So, I tell my fellows when they're graduating, they're going to go work in a private hospital. You don't do iliac arteries if you don't have covered stents, because you always want to be able to take care of patients and your complications. So that's the biggest concern I have.
And that's a good question. So if you are having something with the aortoiliac, is ask your doctor, do you have these on hand? And I think that's an important point.
I mean, that'll save your life.
Yeah.
My doctor's concern was potential injury to the aorta if he attempted to recanalize the
recanalize, yeah.
Yeah, I mean, I'm not really sure what that injury would be, to be totally honest with you, because depending on, I wasn't there, I didn't see your angiogram, but I mean, iliac occlusions are a pretty commonly treated pathology, and people have been treating iliac occlusions endovascular since the 90s. So yeah, I would say that I'm sure if you got an alternative opinion, they may tell you need aortobifem, but I guarantee you that most people would not recommend Fem Fem bypass.
Understood.
Claudication.
Yeah.
Understood.
But if you are experiencing that, see how far you walk. You were saying that you're doing pretty good walking. See how far you can push it. See if you can develop those collateral vessels. Now that your right leg is doing fantastic, see if that'll help you to walk a little further, walk a little faster, and also start growing those collateral vessels. Because the longer you can put off a procedure, the better, because it is that revolving door, right? At some point, but you want to keep kicking the can down the road further and further so that you're not constantly getting a procedure done.
100%. I think that is the best advice you could get.
Right.
Well, thank you. I
Thank
learned
you
from
so
the
much,
best.
Dr. Siah.